female 25 with post-corrosive ingestion can result in complex pharyngeal and esophageal stricture, often require multi-stage reconstruction. Airway compromise and dysphagia are major concerns requiring coordinated ENT and GI surgical management. This patient, female 25, having corrosive ingestion, in which stage first pharyngoplasty was done 3 months back. After that, planned intercolon interposition graft was done by the Dr. Hitesh Patel Patan. And that time, this reconstruction or esophagocolonoplasty was done. And after 2 months of first stage surgery, that patient taking orally very well. After that, this third stage direct laryngoscopy with bronchoscopy was done to check the intactness of the trachea or any granulation in the trachea. You can see this tracheostomy tube inside the lumen. After removing this tube, you see entire trachea is absolutely normal. At 3 months before, this patient having granulation in the trachea at the site of stoma. In stage 1, that granulation was removed. After 1 month, this reconstruction was done by intercolon interposition graft. And now this time we are planning to remove the tracheostomy tube after confirming the trachea and vocal cord mobility. Both vocal cord was normal. Now this bilateral tube bend was there over the vocal fold and over the colonoplasty side. So after removing this two bends from this coagulation vent, we are planning to remove the tracheostomy tube. Now this case is now after doing this bend release able to take orally as well as can breathe through the nose. So this complex case of post-corrosive injury now able to swallow as well as able to breathe orally normally. This endoscopic release of fibrotic pharyngeal vent by using coagulation is very simple approach to release these vent and open up this airway in the case of bilateral vocal fold mobile. Advantages of endoscopic release of fibrotic pharyngeal vents using coagulation are minimal thermal damage by this technique, better precision in scar tissue removal, and reduce bleeding. These are the major advantages of this coagulation vent technique. Decannulation decision based on normal bronchoscopy, bilateral vocal cord mobility is the must. You have to check mobility of vocal fold, otherwise patient may aspirate. So if bilateral vocal fold are mobile, you can remove the tracheostomy tube. And adequate airway post vent release should be checked. This in this case, after removing these vent, successful tracheostomy removal was done. Now patient taking oral feed and breathe through the natural airway. And you have to check for stridor, aspiration, and dysphagia recurrences. So, key discussion is here. Corrosive injuries require multidisciplinary stage approach. Airway assess by airway patency, bronchoscopy, and glottic function, vocal cord mobility should be checked. Coagulation is highly effective for pharyngeal stenosis and scar bend release. In conclusion, this case demonstrates that structured stage management, including colon interposition, endoscopic airway assessment, and coagulator assisted pharyngeal release, can achieve safe decannulation, restoration of oral feeding, and excellent functional recovery for the patient. So, even in difficult cases, we should try to do whatever needed and result will come. It depends on the functional and this integrity of pharyngeal musculature and level of the stenotic segment at the pharyngeal level. These all decides which case should be done and which case will be benefited by the coagulation assisted pharyngoplasty approach. So these are very rare cases you can do and you can manage accordingly.